Hello, good evening everyone. Thank you for joining us today for this webinar. Before we proceed further, I would like you to press the raise hand button on your screen so we can make sure that you are able to hear us. I will wait for few seconds so that we can make sure that you are able to hear us. Thank you. So this is Amin Fateh. I am Chief IT and Chief Operating Officer at Avalon University School of Medicine. And once again, good evening and welcome to this webinar. It is a pleasure to have Dr. Arja with us tonight. Dr. Arja is the Dean of School of Medicine, and we will be taking questions during this webinar, and he will answer all the questions at the end of the session. To ask the question, you can type your questions in the question box. And now I will hand over the session to Dr. Arja. Dr. Arja?
Yes, sure. Thank you, Dr. Min. Thank you very much. Good evening, everyone. This is Dr. Sateesh Arja, and I'm the Dean of School of Medicine for Avalon University School of Medicine. Today, we are going to discuss about evidence in clinical assessments, which include workplace-based assessments and current practices and new directions for health professions education. Before starting my webinar today, I just would like to thank Dr. Amin for giving this opportunity, providing a wonderful platform to present these webinars. And also, I would like to thank all healthcare professionals, including physicians, nursing staff members, and other healthcare professionals who are working day and night during this pandemic. And we all know that how much tough times we are going through. And during these tough times and unprecedented times, the clinical faculty are still committed to teach our students. They are still committed to assess our students and providing what you call right feedback to the students, and also helping the university in assessing our students so that the students can graduate at the end of 4th year. And that's why I would like to thank all physicians for putting their efforts in helping Avalon University School of Medicine and also preparing future physicians. Thank you. Please, next slide, please. Before going into the discussion of clinical assessments for today, I would like to keep an observation on this slide that you can see here, which is Miller's Pyramid. And this Miller's Pyramid, actually, it was published in Academic Medicine in the year 1990, but still it is one of the best practices or best evidence that can show us that our assessments are valid, reasonable, and constructively aligned with the teaching methods and syllabus, and even including the curriculum. And when you look at the different assessments, these different assessments are used to assess the different levels of the students. For example, if you look at the student level, nose level, what are the different assessments that we can use to assess the nose level? You can see here multiple choice questions, essay questions, and oral examination. But when it comes to the student knows how, because he is not only knowing the information of knowledge, but he is also able to apply that knowledge into clinical scenarios, that what we call it as knows how level. Here also we are going to use multiple choice questions, essay questions, and oral examination. But there is a difference between the multiple choice questions that we use for the student level knows and knows how level. But what is the difference in the multiple choice question? Here we are using the multiple choice question to assess the student, what you call application, and also analysis of the information. That's why when we administer multiple choice question here, most of these questions are either clinical scenario based or clinical VNATs. Then next level of the student, which is we call it as shows how. To assess the shows how level, we are going to use mini clinical examinations, objective structured clinical examinations, standardized patient based assessment. And mini clinical examination has gaining importance nowadays. Many universities, many medical schools are using a mini clinical examinations. But when it comes to the objective structured clinical examination, is a known assessment method and is very well used in the medical education, and it is there for many years. I think it started in around 1970s. And here in objective structured clinical examination, we have seen step 2 CS examination also in the past. It's a kind of ASCII examination where medical schools are going to use 8 to 12 standardized patient-based assessment, where students go through one patient to another patient and will assess the patient and will write the SOAP notes. And when it comes to the last level, which is the highest level, which is we call it a student does level, here it is not that easy to assess the student DAS level because it's logistically difficult. These include patient outcomes, peer ratings, but one of the DAS level method of assessment is electronic patient portfolios or logbooks. Recently, Avalon University School of Medicine introduced electronic patient logbooks and portfolios in the assessment system of clinical student. This is just basic understanding, but we use different assessments so that we can assess the different levels of the student. We are going to use multiple choice questions, and also we are using mini clinical examinations, and we are also using ASCII, and we are also using SP-based assessments, especially in the basic sciences in the clinical skills course. We are using a standardized patient-based assessments. Next slide, please. And in this webinar for today, we are going to cover overview of assessment concept, shifting trends and directions of assessment in the medical education, workplace-based assessments, and how to give effective feedback to the students. These are the 4 concepts that we are going to discuss today. Next slide, please. So you can look at this slide. So what is the importance of this slide? We are assessing the students' skills, competencies. Not only we are assessing the students' skills and competencies, but we are also assessing the behaviors. It's not just one behavior, but it's a group of behaviors. But when it comes to the behaviors of the students, these behaviors of the students can change during test situation and non-test situation. Why? Because when you tell the student, I'm going to assess you for a grade, his behaviors will be different. But when you tell the student, or when you don't tell the student that you are observing the student, then his behaviors are different. So we need to balance between what you call assessing the student, especially when you are assessing the behaviors of the student during test situation and non-test situation. How can we do this? Because we are going to use different sampling methods and different standardization structures. And here for the assessment, 2 important characteristic features that we need to have is generalizability. That means we should be able to administer these assessments to different types of students. Not only the generalizability is important, but validity is also important. What do you mean by validity? Validity means accuracy. The accuracy, what does it mean accuracy refers to? Accuracy refers to what you call, does the assessment reflect what is given in the curriculum? Does the assessment reflect what learning objectives are required, or what learning outcomes are intended to acquire by the students? That is the most important thing. What do you call it as accuracy? So the content of the assessment should reflect the curriculum, the syllabus, and the learning objectives. But not only that, the different teaching methods that we use for the clinical students. So this is what we call it as constructive alignment, Biggs constructive alignment. When we align goals and objectives with the teaching methods and assessment methods, then we call it as those assessments are valid assessment methods. Next slide, please. Next slide. So the practical guidelines, the practical guidelines of the assessment. Next slide, please. Next slide. So here you can see the practical guidelines of the assessments. The one important feature of the assessment, as I discussed in the earlier slide, validity or accuracy of the assessments is important. Equally, reliability of the assessments is also important. What do you mean by reliability? For example, you can see in the first what you call diagram, student have taken test 1, he passed the examination, and then he took the test 2, he passed the examination. That means there is a reliability of the assessment, and there is also consistency of the assessment. But if the same student has taken test 1, he passed on the examination, but when he takes the test 2, he failed on examination. That means there is a lack in the reliability of the assessment. I'm talking about what you call, when you compare the test 1 and test 2, the content of the assessment should be the same. Then only we can compare between what you call passing and failing between the 2 assessments. If the content is different, or if we are assessing the student for a different level, or if we are assessing the different content, then we are not comparing between the 2 assessments. But when you are assessing the student between test 1 and test 2, and if the content of the assessments are the same, and then it should give the same result. That's what we call it as reliability. But how can we increase the reliability of the assessments? Next slide, please. So this is the most crucial diagram when it comes to the clinical assessments. How can we increase the reliability of the assessment? By giving number of observations or by giving number of assessments. So we all know that clinical faculty members give end of rotation evaluation. But when they are giving the end of rotation evaluation, they are observing the student. They're not observing this. They're not observing the student for 1 day, but they are observing the student for 6 weeks in 6-week rotation. They're also observing the student for 12 weeks in 12 weeks rotation. So they are doing repeated observations. By doing repeated observation, they're assessing the student. Then there could be more reliability of the assessment. It's not only in case of clinical assessment, even for multiple choice questions also. When you increase the number of multiple choice questions, then the reliability of the assessment or the reliability of the test will be better. That's why, as I said earlier, this diagram is very crucial for the physicians when they're assessing the students, when they're giving the final assessment of the student. That should be based on repeated observation. Even when you look at the regulatory documents or even accreditation documents, they are going to ask us, are the physician are assessing the students based on repeated observation? Yes, they are going to assess the students based on repeated observation, certain number of days. Next slide. And this is also a very thought-provoking slide for us. When you look at 2 different assessments, you can see the different 2 different assessment. The scores of the students are represented by blue dots. That is one assessment. The another assessment, which is represented by red dots. Which one do you think is better assessment? Do you think the scores represented by blue dots or the scores represented by red dots? Obviously, it is the scores represented by red dots. The reason is, when you look at the scores in the blue dots, all of those scores are clustered. That means we are not able to differentiate between one learner to another learner because all of them have the same kind of scores. But when you look at the red dots, you can see the lowest score is around 75. Another highest score is around 92. That means there is a difference between a good performer and a bad performer. That is very important while assessing the student, because we need to be able to differentiate between a good performer or a bad performer, especially when it comes to the students. And it's also one of the comments given by the accreditation bodies or regulatory bodies. When we look at the evaluation forms for the students, we don't see the difference of the comments between one student and another student. And or maybe it's also very important to give the narrative comments. The reason is, when the student apply for residency also, they look at the narrative comments coming from different rotations. When we are able to differentiate a good performer and bad performer, especially a good performer will get what you call benefit out of it. The reason is, when we give good evaluation to the students based on what you call his performance during rotations, it will be very helpful to the students when he applies for residency. So whatever the assessments that we give for the students, we should be able to differentiate between a low scoring student and also high scoring student. We should be able to differentiate this. This will be helpful when they represent these evaluations for either for medical students performance evaluation, MSP, or even for what you call other reasons. We should be able to rank the students based on the assessment. That is very important. Next slide. And another important feature of clinical assessment, the case specificity. What do you mean by case specificity? Is that what you call a student who performance on case 1 very good doesn't mean that he should be performing well on case 2. His performance on case 2 can be poor, and his performance on case 3 can be moderate also. So that means the student performance changes from one case to another case. For example, a student performs very well on a chest pain case. Doesn't mean that students should perform well on a cough case or maybe what you call breathlessness case. This is what we call case specificity. It's very specific for clinical assessments. The next one slide, next slide. So this is also a very important diagram for clinical faculty members or physicians to understand. We give different assessment methods to the students. We don't depend on one assessment method. When you look at what you call clinical examination, see, you can see here, this is, one way of what you call giving the final grade. It doesn't mean that we are following the same final grade when it comes to the Avalon University School of Medicine. So if you look at the clinical examination or observation by the physician, which carries 20% of the final grade of the student. When you look at the reliability of this exam is 0.6, that means 60%. Reliability is only 0.6. When you look at ASCII examination, objective structured clinical examination, the total score, the final grade comes from ASCII, which is around 40%. But when you look at the reliability of ASCII is the lowest, is 0.5. When it comes to the multiple choice questions, the final grade for coming from multiple choice question examination is 40%. When you look at the reliability of for multiple choice questions is very high, is 0.7. But we are giving all these kinds of assessments for clinical students. We are giving clinical examinations, we are observing the students, we are doing ASCII examinations for clinical students, we are giving multiple choice question examinations to the students because we are giving NBME shelf examinations. When you combine the reliability of all these assessments, when you look at the reliability, what we call it as composite score of reliability, or maybe you combine the reliability of all these assessments, then the reliability is high, which is 0.75. When it comes to Avalon University School of Medicine, we do clinical examinations. Physicians observe the students during rotations, and the total grade, which is coming from physician evaluation or physician observation, is almost like 70%. That 70% comes from physician evaluation, which also includes logbooks and multiple choice questions, which we call it as NBME shelf examination. They carry 30% of the grade for Avalon University School of Medicine. And we also conduct ASCII examinations, but clinical students take ASCII examination at the end of the 4th year because ASCII is a requirement for our graduation. One of the requirements for graduation or graduation criteria is passing a objective structured clinical examination. So that's why we need to give multiple assessment. We cannot depend on one assessment when it comes to the clinical students. Not only the clinical students, even the basic science students also. The meaning of this slide is we should be able to evaluate and assess the students throughout the program, throughout the 4-year program, with the use of different assessment methods. We cannot depend on single assessment. This is the new trend in medical education, using different kind of what you call assessments. Next slide. So here I would like to discuss about two things. One is called what you call thoroughness checklist. Another one is called discriminating checklist. What is the difference between thoroughness checklist and discriminating checklist? Now, I will show you what is the difference between thoroughness checklist and clinically discriminating checklist. Can we go to the next slide, please? Okay, here you can see the checklist. Here, the case of the patient case is a joint pain. And when you look at the items, there are 16 items under the history taking, and there are 4 items under the physical examination. So when it comes to the history taking, you can see the different what you call items that we give what you call tick mark. Elicited information about other medical conditions, current medications, describe the pain, onset of pain, radiation of pain, location, all these things you can see here. And under physical examination, assess the passive movements of the knee joint, bilaterally manually inspected knee for warmth, have patient flex and extend the left knee. All these things will come under physical examination. When you use all these items for the checklist, we call it as thoroughness checklist. But when we use only specific items, like for example, asked about the other medical conditions, like past medical history, asked about current medications, that means medications history, and asked anything if like this happened before, these all come under clinically discriminating. That means very few specific questions which will be very helpful for the differential diagnosis and which will be very helpful coming at the conclusion or the final diagnosis of the case. These are called as clinically discriminating checklist. Which one is better, do you think? Do you think what you call thoroughness checklist is better or clinically discriminating checklist is better? Actually speaking, for clinical students, we need both. Why do we need both? For example, if you take a student who is beginning clinical career, who is in the 3rd year, just begin the clinical rotations. At that point of time, we need the thoroughness checklist. The student should be able to have a broad vision at that point of time. You should be able to think of different things. That's why at that point of time, we use the thoroughness checklist. But when the student comes to graduation, maybe he's getting graduated, or maybe he's coming for what you call ASCII examination, or maybe he's going into the residency, he's in the 1st year of residency, then we need higher level of functioning. That's why we need what you call clinically discriminating checklist. What does it mean is, I would like to give like in a nutshell, for beginners, for early career students, we need thoroughness checklist. For higher level students who are almost getting into residency, we need clinically discriminating checklist. But for example, if you look at the what you call checklist that used by Avalon University School of Medicine for our clinical student, we use thoroughness checklist. For all core rotations, we use what you call thoroughness checklist. And also our physicians assess the students based on 6 competencies. Those 6 competencies include medical knowledge, patient care, professionalism, communication and interpersonal skills, system-based practice, and practice-based learning. Those 6 competencies are there. So we are going to use thoroughness checklist for the early career students, and we use clinically discriminating checklist for higher level of students. Next slide, please. And this is also very important for the physicians to understand. There are two kinds of rating scales. One is called standard rating scale, which is commonly used one, and which is most commonly used by the most of the medical schools. And the another one is construct aligned scale. What is the difference between standard rating scale and construct aligned scale? When you look at the standard rating scale, it's like a Likert scale, on to 1 to 5 or 1 to 7 or 1 to 10, whatever it is. It depends on the medical school. Some schools use 1 to 5 scale, and some schools use like 1 to 7 or 1 to 10. For example, for Avalon University School of Medicine, we use what you call below expectations, average student, above average, and excellent. Like that, we rate the students. When you look at the standard rating scale, for example, rating 1, critically deficient student, that means he's not performing well and he is very deficient. When it comes to the rating 4, he can manage the patient unsupervised practice. But of course, most of the clinical rotations that we do, in most of the clinical rotations, whatever the students practice is mostly supervised practice. Generally, we don't leave the student like that. When it comes to the rating 5, is like an aspirational student who can do an excellent job. That is called rating 5. That is called standard rating scale. As I said earlier, most of the medical schools are using standard rating scales. But nowadays, the trend is towards the construct aligned scale. What do you mean by construct aligned scale? Every rating that you give for construct aligned scale is defined, is clearly defined what rating should be given to the student. For example, the lowest level, if you look at the lowest level, doesn't use any consultant services. That means he doesn't contact the consultant at all for what you call managing the patient. When you go to the next level, he is able to contact the consultant, but he is not able to identify what is the reason why he contacted the consultant. He's not able to present his case very well to the consultant. Then that is the next level. The next level goes to the next level is what you call ask meaningful clinical question to the consultant. That is the next level. Then the next level is he can take recommendations from the consultant and he can implement those what you call recommendations into the patient care. That is the next level. But when it goes to the last level, the highest level is he can take what you call input from different consultants and he can manage the patient. That's what you call the highest level of what you call a student. So here, every level of the student is clearly defined. So by looking at these two scales, you can clearly say that construct aligned scale is much more valid and is much more better when compared to the standard rating scale. The reason is standard rating scale always will have a subject bias. Even though we say that there is no bias when we give the standard rating scale, in most of the cases when we use the standard rating scale, it will be biased. To avoid this bias, which is associated with the standard rating scale, nowadays in health professions education, we are going more towards what you call constructed aligned scale. So that's what I would like to say about what you call standard rating scale and construct aligned scale. Next slide, please. So before going into workplace-based assessment, what we discussed so far, I would like to just re-emphasize the facts is that whatever the assessments that we give should be valid. That means they must be accurate. The one way of giving accurate assessment is our assessment should reflect the content of the syllabus, the learning objectives, and our teaching methods. And whatever the assessments that we give, they must be reliable. One of the way of improving the reliability of the assessment is by doing repeated observations. We should observe the students as many times as possible, as many days as possible, so that we can give what you call reliable assessment to the students. And we are required to use both what you call thoroughness checklist and clinically discriminating checklist. The reason is thoroughness checklist will be useful, especially when we are assessing the early career learners, and clinically discriminating checklist will be useful when we are assessing the higher level of students. And the last but not the least is what you call construct aligned rating scales are much better than standard rating scales. And when you look at this slide, you can see the workplace-based assessment. And workplace-based assessment is one of the what you call the recent trend in medical education. But I cannot say recent, but because we are using workplace-based assessment more than 15 years. And here in workplace-based assessment, as I told you earlier, the most key factor is repeated observations. So here, the student is directly observed by the faculty member. It's what we call as direct observation. When you do the repeated observation, we can give the end of rotation evaluation. When it comes to the clinical department of Avalon, we receive the end of rotation evaluation from the physician. But when you look at the end of rotation evaluation, that could be a reliable source of what you call assessing the student, or that could be a reliable source of giving a grade to the student only when physicians do the repeated observations. So that's why workplace-based assessments, which gives repeated observations, are very critical for assessing our clinical students. So what I'm going to use in case of what you call direct observations are workplace-based assessment. Basically, you can assess the student skills for a history taking, or maybe physical examination skills, or maybe if the student is using appropriate physical examination techniques or not. So those all come under what you call workplace-based assessment. Next slide, please. So workplace-based assessments are very important when it comes to the end of rotation evaluations, because the reason is faculty are observing the students on repeated occasions and then they are giving the feedback. But not only just the faculty, but we need to depend on what you call multi-source feedback. What do you mean by multi-source feedback? So you can see on the right side, you can see the encounter 1, encounter 2, and you go on, encounter number of n times. So we are doing repeated observations, but not only we are doing the repeated observation, but we are also depending on the different people to give end of rotation evaluation. One is definitely supervising faculty, which is attending physician. Of course, he's going to give feedback on the student, but he must be able to take the feedback even from the learners, other learners, which are peers of the student. And also he must take feedback from the nursing staff, because there will be other healthcare professionals on the floor, which includes nursing staff or other healthcare professionals, and even residents. There could be residents also who are rotating in the same rotation. So the physician can approach nursing staff or residents to take the feedback about the students. When he combines the feedback of all these people into his own feedback, then it gives the reliable assessment of the student. So that's what we call it as multi-source feedback. Next slide, please. So shifting trends and directions in assessment. What do you mean by these shifting trends and directions in assessment? Next slide. So you can see here, this is what you call one way of representing our learners. If you look at the student or learner, whatever you call it as, he's like a tea bag. And we keep him in the hot water. For how long we keep him in the hot water? For 4 years? Maybe if the program is for 4 years, like American education system, or maybe for 6 years. For example, in the European system, we have this MBBS program or MD program for 6 years. We keep them for what you call 4 years or 6 years. And we assess the student. This is what we call as continuous evaluation of the student. We don't allow the student to graduate without this continued evaluation throughout the program for 4 years or 6 years. Same thing, whatever we are doing in the basic sciences, we are assessing the students throughout the semesters and all 5 semesters. And then we are assessing the students throughout the clinical rotations, all 6 semesters. So at the end of what you call 4-year program or whatever 6-year program in other countries, at the end of 6 years, the student should be able to graduate. When the student graduates, he should be able to be a competent physician. For that, we need to assess the skills and competence of the students throughout the program. That is what we call it as what you call recent trends in medical education. Next slide, please. So in the previous olden days of what you call medical education, we used to use single assessment for anything. For example, if you are assessing the student in the 3rd year or maybe 4th year, one assessment will be there for each rotation. But now it is not single assessment anymore. It's a system of assessment, continuous assessments. So when we administer the single assessment, the different factors are the different what you call qualities of assessment methods, which include validity of the assessments, which we already discussed, accuracy, and educational effect. That means by assessing the student, it should have an educational effect of the student. That means it should impact what you call education of the student. And it should have what you call changes in the learning behaviors of the student. That's what we call it as educational effect. And not only educational effect, but the assessment should also have catalytic effect. That means it should improve the learning environment. So that what we call it as catalytic effect, which promotes the learning of the students. So these are all what you call qualities of the assessment. But now the trend is changing. There is a system of assessment. There is a series of assessments, a continuous assessment of the student, continuous evaluation of the students. But all these assessments should be coherent. What do you mean by coherent? One assessment that you give for internal medicine should have a link to what you call another assessment that we give another rotation, or the assessments that we give in the first year of this medical school should have a link to the assessments that we give in the second year. The same way, the assessment that we give in the third year of the clinical rotation students should have a link for the fourth year students. That's what we call as coherent, what you call assessment. And these assessments should be comprehensive. That means we should be able to thoroughly assess the student. And these assessments should be feasible. That means we should be able to administer. I can give 100 types of assessments. I can give examples of 100 types of assessment. Suppose, for example, if the faculty member is not able to administer those assessments, if the medical school is not able to administer those assessments, if the administrators are not able to control those assessments, those are not feasible assessments. So we should be able to, what you call, advise the faculty which are feasible and purpose driven. What is the purpose here? The student should be able to graduate. The purpose is what you call, we should be able to graduate not only just a student, but we should be able to graduate who can be a competent physician. That's what we call it as purpose driven. And also the assessment should be acceptable. Acceptable to who? They should be acceptable to the faculty members. The assessment should be acceptable to the students or learners. And also the assessment should be transparent. So these are the different qualities that we look at when we see a valid assessment. And all these assessments should be embedded within the instruction or clinical setting. Not only giving the assessment, but at the end of the assessment, you should be able to give feedback. Not just the feedback, it should be actionable feedback. That means students should be able to work based on the feedback that is given by the faculty members. The students should be able to work based on what you call the feedback that we give to the student. The student should be able to improve based on the feedback that we give to the student. That's why we call it as actionable feedback is very important. And not only the actionable feedback, but it should be able to helpful ongoing and growth of the mindset of the students. And the most importantly, the feedback that we give for the student should be timely in manner. Suppose, for example, if I give assessment or if I evaluate the student and maybe June of this year, and if I give feedback to the students in December, it doesn't make any sense to me. The reason is what you call, whatever the feedback that we give to the student should be in a timely manner so that the student can improve, and he can improve what you call in a way that he can improve his learning behaviors. And he can improve his own what you call competencies and skills based on the feedback that we give to the student so that he can perform better in the future experiences, in the future assessments. That's the meaning of what you call timely feedback and actionable feedback. Not only that, whatever the feedback that we give to the student should be able to, what you call, the student should be able to understand it. Not only the student should be able to understand it, he should be able to, what you call, improve his cognitive behaviors, or what you call his aptitude for sciences should be increased when we give what you call feedback to the student. He should think that based on this feedback, I can improve my what you call learning behavior. I can gain more knowledge from somewhere else. I should be able to focus on cognitive learning also. These are the what you call different, what you call, what should I say is that these are the different key characteristic features of the assessment. Whatever the assessments that we give should be coherent, it should be continuous, they should be comprehensive, feasible, and acceptable and transparent to the students. And we should be able to give timely feedback, and we should be able to improve the students what you call learning behaviors. Next slide, please. So here, I'm going to speak about for 5 to 10 minutes about workplace-based assessment. What are the different workplace-based assessments available to assess the clinical students? Maybe if you look at this slide, you can see the different names: mini clinical examinations, case-based discussions, direct observation procedure skills. That means when the student is performing a procedure, you should observe the student. When it comes to the medical students, they are not required to perform each and every procedure that I come across. Some of the procedures for medical students, they should be able to observe, but some of the procedures they should be able to perform, because they are still at what you call medical student level. They don't need to perform each and every procedure that they see, but they should be able to observe certain procedures and they should be able to perform certain procedures. That's why we also require direct observation procedure skill assessment also. And the last but not the least is clinical work sampling. All these four what you call workplace-based assessments were clearly defined, clearly explained by one of the article published by Narsoni, John Narsoni. His name is John Narsoni. He was the previous president of FAMER and ECFMG. and he published this paper in 2007. This paper can be considered as one of the gold standard paper for workplace-based assessments. Next slide, please. And this is the what you call a sample format for mini clinical examination. You can see here. When it comes to the mini clinical examination, this is the form released by ECFMG. Why ECFMG has released mini CX? Recently, all of you know that ECFMG has cancelled step 2 CS examination. And because of cancellation of step 2 CS examination, they are asking the medical schools to certify for clinical skills. The one way we are certifying our clinical students for clinical skills is by looking at the evaluations from clinical rotations. If they have done 3 core rotations, and if you have seen 3 core rotation evaluations, we are certifying them for what you call clinical skills. But some of the students may not be able to finish what you call 3 core rotations. Then in that case, we are asking to get what you call certification for mini CX from the physicians. They should get 3 mini CX evaluation forms, at least from 3 physicians. That's what we are looking at. That's why the ECFMG has released this form for mini clinical examination. So what physicians should evaluate while they are doing mini CS examination? You can look at this what you call form. Medical interviewing skills, which includes what you call history taking, accurate history taking, and organized history taking. And the next one is physical examination skills, appropriate physical examination techniques, appropriate physical examination procedures, and organized physical examination. These are all the things required under physical examination skills. And not only that, they should be able to assess the professionalism, how they are behaving in the patients. Are they showing the respect? Are they showing compassion? Are they showing empathy towards the patient? Or maybe they are what you call communication skills with the patients in a respectful manner. And overall clinical reasoning and judgment. What do you mean by clinical reasoning and judgment? The student should be able to form the differential diagnosis, and not only just forming the differential diagnosis, but they should be able to give what you call management and investigations required for the patient. So based on that, based on all these the checklist, the physician can evaluate the student and can give the mini CX form. So this is very important assessment method for clinical student, and this is one of the commonly used ones actually across the medical schools. Mini CX forms is one of the very commonly used way of assessing students in the clinical rotations. The next slide, please. So this one is direct observation procedure skills. As I mentioned earlier, direct observation procedure skill generally used while the student is performing a procedure. So maybe, as I said earlier, medical students are not required to do every procedure that they come across. Some of them they are required to observe, but definitely some of the procedures they are able to perform. Next slide. So when a student does a procedure, how do I assess the student? So you can see here different different checklists that we are using to assess the student while they are performing the procedure. Demonstrate and understand indications, relevant anatomy, technique of the procedure. You should be able to understand the anatomy, why he is doing the procedure, and obtains the informed consent from the patient. This is very important, how to take informed consent from the patient. And demonstrate appropriate preparation for pre-procedure. That means he should do what you call appropriate preparation, maybe required analgesia and safe sedation and technical ability, aseptic technique, seeks help where appropriate, post-procedure management, and not only that, how he is communicating with the patient, consideration of patient professionalism. These are all different things that you can observe while the student performing the procedure. Based on these different checklists, you can assess the student and you can say that whether the student is able to perform the procedure or not. And if you look at our rotation evaluations, not only the rotation evaluations, if you look at the core clinical encounters, because we have core clinical encounters for each rotation. We have core clinical encounters for internal medicine, surgery, OBGYN, or even family medicine. There are certain procedures listed on the core clinical encounters. And also it is listed that some of the procedures should be observed by the student and some of the procedures should be performed. And this is the form that the physicians can use while they are assessing the students, when they are assessing the student while they are performing certain procedures. Next slide, please. And this is also a very famous way of assessing the student in clinical rotations, case-based discussions. This is also in use for a long period of time. What do you mean by case-based discussions? Here, the patient will be there, and the student will do the history and physical examination. Based on that, he will prepare the SOAP notes and he will present the case. That's what we call it as case-based discussions. So what we do in case-based discussions, or what we assess in case-based discussions, you can see on the next slide. Next slide, please. So here you can see this. So when we are presenting a case, as a student, if I'm presenting a case, so you should have medical record keeping. That means what you call, you should be able to represent appropriate history and physical examination. Based on the history and physical examination, you should be able to clinically assess the student. The student should be able to assess the patient. And the student should be able to tell what are the different investigations required or referrals required. Maybe even in some cases, they should be able to come up with the treatment plan, or they should be able to tell the treatment plan and follow up and future planning. And of course, definitely we are going to assess the professionalism of the student and overall clinical judgment. This is a very simple form that we can use for case-based discussions. So these are the three different what you call clinical workplace-based assessment. One is mini clinical examination, another one is direct observation procedure skills, another one is case-based discussions. But most commonly used ones are definitely mini clinical examinations and case-based discussion. These are the two commonly used ones. Even if you look at our syllabus and our curriculum and all those things, you can see, you can find case-based discussions, various case-based discussions that we use during clinical rotations. The only one thing which I didn't put any form here is the clinical work sampling. What is the meaning of clinical work sampling? How it differs from other workplace-based assessment? Clinical work sampling is very peculiar way of assessing the students in clinical rotations. In clinical work sampling also, we are going to use the same checklist: history, physical examination, maybe what you call differential diagnosis, investigations required, management of the patient, treatment plan. We use the same what you call checklist even for clinical work sampling also. But only difference is in clinical work sampling, we are also going to use the nursing staff. It's not only the physician or the faculty member. In clinical work sampling, nursing staff are also involved in assessing the students and giving feedback to the student. That is the major difference between other assessment methods and clinical work sampling. The next slide. Okay, we assess the student. What should I do after assessing the student? We should give feedback to the student. And these are the principles in giving what you call assessments. These are also principles mentioned by the same what you call the same publication, Workplace-Based Assessment, which is published by Narsoni. And feedback are being timely and specific. As I mentioned earlier, when we conduct an assessment, it's better to give the feedback to the student as immediately as possible, because that can improve the learning nature of the student, that can improve the future learning of the student. That's why we should be able to give feedback. And another important key feature when we are giving feedback to the student, it should be specific. What do you mean by specific feedback? The meaning of specific feedback is that when you look at the what you call clinical rotation evaluations, you can see some of the comments written by the what you call physicians. They say that what you call student is very hardworking. Yes, it's very important for the student to know that, because we are letting the student that the student is very hardworking. But when it comes to what you call a specific feedback, that may not be that much helpful to the student, because we need to give specific feedback to the student in the sense in which area the student did very well and which area student didn't do very well. That's what we call specific feedback. And not only that, when you look at the comments, suppose for example, if the physician says that students should be able to put more hours into what you call studying, or maybe should be more hardworking, that also may not be helpful to the student. Because when you say that what you call, he should be able to put more hours into it, but we should guide the student where the student should be able to get the required resources, where the student should be able to get the required information. We should be able to guide the student, and what students should be doing, that also should be mentioned in the what you call evaluations. But if you look at the most of our evaluations, we see mostly what you call positive evaluations. That means mostly we see only strengths of the students. We see very less often areas of improvement required. It's very important when we give feedback to the students to give areas of improvement also, especially when it comes to the formative assessments, because the reason is formative assessments are very helpful to the student to change his learning behavior, to improve his what you call learning behavior. That's why it's very important for the physician to give what you call the areas of improvement where the students are required to work hard or work more. So that is more helpful to the student. And as I mentioned earlier, feedback should not be vague or generalized. And also very important thing is what you call encouraging the students and faculty members, both of them, in what you call in implementation of what you call formative assessment and getting feedback. It's very critical to have this kind of what you call engagement of the students and also the faculty members. That is the critical engagement of students and faculty members is the critical in giving feedback to the students. Next slide, please. And this is the last slide, but definitely this is not the least slide. And when we give feedback to the student, we should be able to clarify any matters of fact. If there is any what you call information that we need to do, or if we need to clarify any what you call information, we should be able to do it during the feedback. And also we should ask the student what went well, and then we can discuss, the physician can discuss what went well, and the learner can discuss what you call the areas of improvement. This is very important. Maybe the student should be able to identify himself, what are the areas of improvement, what are his weaknesses. He can identify his own weaknesses, and then the faculty member or physician can tell where the student is required improvement. And the last but not the least is action plan agreed upon. This is very important. We should be able to what you call respect the values and beliefs and learning behaviors of the student. And according to the beliefs and what you call whatever it is, the learning behaviors of the student, based on that we should come up with a plan where the physician and also the learner, the faculty member and the learner come to a common action plan which will be helpful to the student. This is what we call as joint action plan. This joint action plan is very important for giving feedback and also for the improvement of the student. Thank you so much, and this is it for today's webinar. And thank you for your time, and thank you for attending what you call this webinar. And this is just what you call a comprehensive review of workplace-based assessment. If anybody has any questions, you can always ask me questions. You can send me an email also if you have any further questions. Thank you, Dr. Amin, for what you call for conducting this webinar, and thank you for your time. Does we have any questions? Do we have any questions?
Let me check that thing for you, Dr. Arja, very quickly. Yeah, it seems we have no questions so far for tonight's webinar.
Oh, thank you so much. It means we can adjourn the webinar. Thank you so much once again for everyone. Thank you so much for your time. Thank you.
Welcome. Thank you for joining us tonight. Have a good night and restful evening.